Kia ora, welcome to this wrap-up session on STEMI Mimics. And if you've made your way through the book, you'll be aware that the basic approach that we have to considering any STEMI mimic is to ensure that it's not an MI first. So clearly we need to be looking for whether the changes are regional and whether there's reciprocal changes. And if this is not the case, or there's other clinical indicators to suggest that it's not an AMI, then we can start thinking about what potential STEMI mimics there are. So STEMI mimics are ECGs that present with repolarization phase changes similar to those that we expect in acute cardiac syndromes. So typically these are going to present as ST elevation or T-wave changes that are similar to those that are associated with a STEMI. So the role in considering STEMI mimics is to avoid code STEMI activations when these mimics appear, and it's an important part of paramedic practice because it prevents unnecessary and potentially harmful treatment when it isn't indicated, and it also reduces the opportunity cost at PCI facilities. So what causes STEMI mimics? Let's take a step back and review why we see ST changes in acute transmural AMI. The cessation of blood flow and oxygen to the affected areas of the heart results in a cellular membrane disruption and the loss of potassium from the interior of the cell to the extracellular space. As potassium is a positively charged ion, the movement alters the voltage of the damaged cell exterior. So, undamaged cells are more negatively charged than what the damaged cells are. Not only does it impact the resting potential of cells, but it also allows for current to flow between damaged and undamaged cells. Because the release of potassium to the cell exterior will be restricted to the region of the heart not receiving any blood, the ECG is going to reflect this as a downward alteration of the resting potential, which makes the ST elevation appear elevated in the area that the damage has occurred in. One further recap. Regional ST segment elevation is caused by altered electrical potential due to damaged cells. So, it follows that anything else that alters the ion balance or produces an abnormal current in the heart will also produce ST segment elevation. And so the remainder of this presentation is going to focus on this. First, we're going to look at a physiological cause of ST segment elevation. And I say physiological because this occurs as a normal variant in some people and has no connection to disease or injury to the cardiac cells. Benign early repolarization is thought to stem from a physiological variation in which the epicardial tissue begins its repolarization phase a fraction ahead of the remainder of the myocardium. In this sense, it produces electrical currents not dissimilar to those seen between damaged and normal myocardial cells. The main distinguishing features is that there is less regionalization, and it's more likely that multiple lead groups are going to reflect this change. Benign early repolarization is more common in younger people, that is under 50 years old, and the more athletic and the more male you are, the more likely it is to happen, although it's not restricted to these populations. It's also more prevalent in situations involving parasympathetic dominance. The early repolarization current produces a concave ST segment elevation, and the ECG often displays a small positive deflection at the end of the QRS complex where it intersects with the ST segment. It's called a fishhook sign, and it appears in any combination of anterior, lateral or inferior leads. And reciprocal findings are very, very unlikely. So, let's have a look at an ECG that displays this. So let's review an ECG showing benign early repolarization. The first factor we can see is a young patient, and the second thing is the obvious inclusion of these fishhook signs, or these small positive slurs that have occurred at the end of the QRS where it intersects with the ST segment. There's normally a steeper downslope on the T wave than there is on the upsweep. But more importantly, you can see that the concavity of the ST elevation is very, very clear and matches the sort of smiley face test that we can give these. And finally, and we'll talk about this a little more later, but the degree of ST elevation is normally quite small in terms of the size, the overall size of the T wave. In terms of clinical correlation with benign early repolarization, other than its likelihood in younger males, there's no other clinical correlation, so no significance that we put on this finding. In terms of differential diagnosis, however, it's important to make sure that it's not a STEMI. So the main factors for consideration are the regionalisation and reciprocal changes to any ST segment elevation which would favour STEMI, therefore that's the decision we would make, or whether there's correlation and clinical examination signs that suggest ACS. The other main thing in terms of differential diagnosis with benign early repolarization is pericarditis. And the ECG changes associated with pericarditis are also generated by anomalous currents but in this case over the pericardium, and they produce concave ST segment elevation and notching of the terminal portion of the QRS as well. The main differentiating features between BER and pericarditis is that the clinical prodrome leading into this is going to suggest pericarditis, so that is there's going to be a source of infection, timeline and development of the symptoms, and normally a classical alteration of the pain when the patient's leaning forward. The second distinguishing factor is going to be the ratio of the ST segment elevation to the T wave ratio in V6. And if this is less than 25%, it favours benign early repolarization over pericarditis. So let's go on to look at pericarditis. The inflammatory process in pericarditis results in a temporary pathological alteration of the repolarization sequence of cardiac tissue. In this case, anomalous currents arise from the changes to the resting voltages of the cells adjacent to the inflammation, and this can cause a current to be conducted to unaffected cells. The change isn't constant over the progress of the disease, and during the first few days, the nature of the change tends to result in a global concave ST elevation and a small positive deflection at the end of the QRS where it intersects with the ST segment, i.e. a fishhook sign. And in the case of pericarditis, the other change which is quite often apparent is PR segment depression. Now when the inflammation resolves, so do the currents, and the ECG returns to normal. The majority of pericarditis presentations are caused by viral infections, with upper respiratory tract infections and gastroenteritis being the most commonly clinically apparent prodromes. So let's go on to have a look at the ECG findings. Firstly, we see a globally apparent concave ST segment elevation alongside PR depression in most leads, which will be normally mirrored by PR elevation in lead AVR. And finally, an ST segment elevation where the ratio to the T wave is greater than 25%. The clinical correlation to pericarditis is that it usually presents with an acute onset of pleuritic pain and a low to moderate fever. There may be a pericardial rub or a cardiac effusion is also possible. And the course of the disease is usually self-limiting and responds well to non-steroidal anti-inflammatories. Problems arise secondary to any effusion becoming constrictive and resulting in a tamponade. Other red flags include fever of greater than 38 degrees and persistent symptoms following first-line treatment. From a differential point of view, there's two to consider. The first is STEMI. The main thing to look for is regionalisation of the ST segment elevation and whether any reciprocal changes to the ST segment elevation would favour the decision that it's a STEMI. And the second point in making a decision around a STEMI is just the correlation of the findings from the clinical examination. The second differential to consider is benign early repolarization, which we've covered in the previous session. The ECG changes associated with benign early repolarization produce a similar concave ST segment elevation and notching on the terminal portion of the QRS. The main differentiating features are going to be, firstly, a clinical prodrome suggesting pericarditis, so that is identifying a source of infection, a timeline, and the clinical nature of the pain, particularly if it's got a positional feature. There'll be PR depression, which will favour pericarditis. An elevated PR segment and lead AVR favours pericarditis. And finally, should the ST segment elevation to T-wave ratio in V6 be greater than 25%, this also favours the determination of pericarditis. Pericarditis is associated with up to 5% of acute chest pain presentations to the emergency department, often self-limiting. The impact of an associated effusion might be life-threatening, so an X-ray is a very important screening tool. Given the association of more chronic forms of pericarditis following the upswing in COVID infections and the non-viral causes such as the COVID vaccine, urgent review for these cases is recommended. The previous two examples of STEMI mimics involve anomalous currents, but it's also possible to produce STEMI-like changes on an ECG by altering their ionic balance across the cardiac membrane. The archetype for this condition is an increase in extracellular potassium. This might happen in one of two ways. The first, an external increase in serum potassium, and the most common cause of this would be renal failure. The failure to excrete extracellular potassium causes it to accumulate, and when it comes in contact with the cardiac tissue, interferes with the electrophysiological properties of repolarization. Similarly, conditions that just force potassium from the intracellular space will have a similar effect. The main drivers for this include unmanaged hyperglycemic states. It can happen in trauma and with crush syndrome, and with some forms of pharmacology, particularly beta blocker or ACE inhibitor and toxicity. A low to moderate increase, that's about somewhere between 5.5 and 6 millimoles per litre, results in tall T waves that might be mistaken for hyperacute T waves, and hence the mimic. As the serum levels increase, the P wave flattens, the QRS complex widens, the rate will slow, and at extreme levels you get the sinusoidal asystole. The remainder of the section is going to focus on differentiating the tall T waves of the hyperkalemia from those that are associated with early STEMI changes. So let's look at the ECG changes associated with this. So in this example, and particularly in the anterior leads, we can see very tall peaked T waves that might resemble those that are associated with the early evolution of the STEMI. From a morphology point of view, the most significant thing about them is how pointy they are. And generally speaking, T waves associated with the early evolution of a STEMI will be quite rounded. And the rule of thumb is if you wouldn't want to sit on them, they're more likely to be hyperkalemia. There's a couple of other clear clues in this ECG. First is that the degree of hyperkalemia is relatively significant to be in that moderate level because we're seeing the widening of the QRS complexes across the entire ECG, and we have this global loss of the P waves across the entire ECG. The most common correlation between the ECG and the condition is going to be chronic kidney disease. Other historical factors to consider are whether there's been widespread tissue damage, maybe someone lying on the floor for a long period of time, whether there's been a crush syndrome, or this opportunity for a beta blocker or an ACE inhibitor toxicity. And the last one to think about in terms of what might cause this is whether you've got someone who's got unmanaged diabetes mellitus or some other form of hyperglycemia. From a differential diagnosis point of view, clearly the thing that we're looking to differentiate it from is the hyperacute T waves associated with an evolving STEMI. And the things that we were looking for were the morphology of the T wave. The pointier it is, the more likely it is to be hyperkalemia. That there's a lack of concave ST elevation associated with hyperkalemia, and certainly you're not going to find regionalised changes associated with hyperkalemia. And there may be a lack of correlation between the clinical examination findings and those that would be associated with some form of acute cardiac syndrome. The clinical significance is that while acute T-wave changes driven by hyperkalemia are not directly associated with cardiac damage or even the likelihood of a major adverse cardiac event, the findings do indicate a high level of overall risk, particularly if the serum potassium continues to rise and we move to those sinusoidal types of asystole. So eventually the cardiac output will be significantly affected. Urgent review is required as the distribution of potassium ions between the intra and extracellular spaces can really complicate the treatment, and therefore monitoring of serum ionic content is essential for the long-term management. The left bundle branch block is one of the most, if not the most common STEMI mimics encountered by paramedics. The electrophysiology in this case is secondary to an alteration of the depolarization sequence in the left ventricle. As the depolarization occurs more slowly and outside of the bundle branch, there are secondary changes in the sequence that drive the ST segment and the T wave in the opposite direction to the main QRS polarity. In other words, if the main deflection of the QRS complex is negative, that is downwards, the ST segment and the T wave will be driven upwards, and this will give it the appearance of ST segment elevation and or a hyperacute T wave. We cover details on the ECG findings in greater detail elsewhere on the course, but the short version is that the ECG is going to show a supraventricular rhythm, most often sinus or an atrial fibrillation, that has a wide QRS. That is to say that the QRS is going to be greater than 0.12 of a second, or 3 small squares. The short version of this is that lead V1 is going to show a very deep QS or RS complex that's wide, while leads 1 and V6 are going to have predominant R waves. But as I alluded to before, there's an entire package on this that you can review to get the exact details. In terms of clinical correlation, it's very minimal, if any, impact on cardiac output. It is present in 1% of all acute myocardial infarctions, and because of the wide QRS and these secondary changes, the STSE criteria, the normal STEMI criteria that we'd apply, are rendered ineffective, and the assessment is going to rely on the modified Scar-Boser criteria instead. And again, there's an entire package on Moodle regarding the application of that particular assessment tool. In terms of differential diagnosis, the first thing to consider with these wide complex rhythms is whether or not it's VT, and so you have to look to see whether there's sufficient evidence that the pacemaker has a supraventricular site. When we consider STEMI, we're going to utilise the modified Scar-Boser criteria. And in terms of clinical significance, the synopsis is that it's normally pointing towards a pre-existing as opposed to an acute cardiac issue. So it may be due to something like left ventricular hypertrophy or a previous MI. Just discussing left ventricular hypertrophy. This is another condition where secondary repolarization changes might mimic a STEMI. The increased mass of the ventricle prolongs the total depolarization time, and in a manner not dissimilar to a conduction block, drives the ST segment in the opposite direction to the main QRS deflection. So, in this way, it can appear similar to STEMI characteristics. The gold standard for the diagnosis of left ventricular hypertrophy is clinical correlation combined with an elevated serum level of BNP. But there are left ventricular hypertrophy indicators on an ECG, and these utilise voltage criteria. They have a low sensitivity, can range anywhere between 10 and 50%, meaning that they're likely to miss left ventricular hypertrophy when it's present. However, the specificity is much higher, somewhere between 85 and 99%, meaning that if you see the changes on the ECG, it's very likely that the left ventricular hypertrophy will be present. There are several criteria, and the one we utilise on this course is the Cornell criteria, which requires the sum of the S wave in V3 with the R wave in AVL to be greater than 28 millimetres in men or 20 millimetres in women. The sensitivity for this particular test is 40% and the specificity 95%, so generally a reliable tool. The clinical correlation is that left ventricular hypertrophy presents with respiratory systems normally secondary to pulmonary edema and a reduction in cardiac output. Positive ECGs might confirm that left ventricular hypertrophy is a contributing factor, or it can help identify risks when you're assessing patients with non-acute presentations and trying to make determinations as to whether they're safe to leave at home or what degree of follow-up is going to be required. So for differential diagnosis, and from an ECG perspective, left ventricular hypertrophy can have very similar features to a left bundle branch block. In fact, the worse the hypertrophy, the more it's going to look like left bundle branch block. From a clinical perspective, acute pulmonary edema can have non-cardiac causes, such as acute respiratory distress syndrome. It can happen with sepsis. There are neurogenic causes, and it can be related to drug toxicity. Given the low sensitivity of the ECG voltage criteria, the ECG itself is insufficient to rule out cardiac causes in its own right. Changes might mimic STEMI is right ventricular hypertrophy. The electrophysiological changes are secondary to the increased mass of the right ventricle. And this is going to increase the overall voltage that's measured, and it's going to shift the QRS axis to the right. And it's these things that can produce the mimic. The voltage and the axis changes can result in tall R waves in the septo-anterior leads and ST depression in leads V1 to V3. Unlike left ventricular hypertrophy though, right ventricular hypertrophy has no specific voltage criteria, and clinicians need to review a cluster of right-sided features including right axis deviation, a dominant R wave in V1, that is where the R to S ratio is greater than 1, a dominant S wave in V5 or V6, this is where the RS ratio is less than 1, a right-sided strain pattern where we get inverted T waves or ST depressions in the anteroseptal leads, so this is going to be between V1 and V3. We get a QRS duration of less than 120 milliseconds, so that's a normal QRS width, but the changes that you see in morphology are going to look the same as those for a right bundle branch block. So what we're talking about is an incomplete right bundle branch pattern. From a clinical correlation point of view, the primary symptoms of right ventricular hypertrophy are a peripheral edema and reduced cardiac output that often manifests as fatigue. While the ECG is not diagnostic, it can help identify those right-sided changes and the underlying causes, or identify risk factors for people with non-acute presentations. From a differential diagnosis point of view, there's no specific differential. You should always consider the impact of chronic obstructive pulmonary diseases and their association with cor pulmonale as part of the genesis of any right-sided problems. The clinical significance, as we've described above, might help explain the presence of peripheral and cardiogenic symptoms, but is not necessarily diagnostic for these things. So let's wrap this up. A summary. So there are various conditions that can alter cardiac electrophysiology, producing either a widened QRS complex with secondary ST segment changes that can alter the T waves, or it can alter the ST segment position or its elevation. So when analysing wide QRS complexes, Assume that the ST segment elevation is a STEMI Mimic. It's essential to consider the QRS width before analysing the ST segment, as those secondary changes associated with the wider QRSs render the usual ST analysis method ineffective. In these cases, when the QRS is wide and it's consistent with a left bundle branch block or an intraventricular conduction delay, you have to use the modified Scar-Boser criteria to assess whether there's any acute ST segment changes or not. The differential diagnosis for peak waves includes early evolution of a STEMI or hyperkalemia, and the main distinguishing features are going to be the clinical correlation between the two cases and the presence of pointy P waves that would favour hyperkalemia and rounded T waves that are going to favour a STEMI. Common non-acute cardiac syndrome causes of ST segment elevation include pericarditis and benign early repolarization. And although these two have similar ECG characteristics, clinical correlation will help distinguish between them. Also, those ECGs that have a ST segment elevation to T-wave ratio greater than 25% favours pericarditis. I'll finish off by reiterating how important it is to look for regional changes, particularly where there's reciprocal change, to confirm the presence of a STEMI. So the default setting is STEMI until there's sufficient evidence to disprove it. I'll leave you with those thoughts, and if you've got any questions, feel free to get hold of me. In the meantime, ka kite.